Hello and welcome to Dental XP. I'm Dr. Maurice Salama and I will be discussing with you today the immediate extraction of a hopeless central incisor in the anterior region. As you can see from the x-ray, the maxillary right central had a fracture of the root and the post space and needed to be extracted. As part of space management, orthodontics was initiated to create an ideal space for the subsequent restoration of this edentulous span. We utilize piezoelectric osteotomes and periotomes to engage the periodontal ligament space of the tooth to be extracted in order to optimize a very careful and atraumatic extraction of the right central incisor. Periotome tips are engaged into the PDL space following the engagement with the piezo surgical, and you can see the large defect and fracture well beyond the margin of the crown. Actually, some external resorption had also taken place on the root surface. You can see the tapered nature of the root really allows us to have a more optimal design for immediate implant engagement and stabilization. Evaluation of the socket space reveals an intact buccal plate and lingual plate, and we always evaluate the socket prior to the initiation of the osteotomies. And one of the things we have to also look out for is the thickness of tissue. And what we've been doing more often in the anterior region is actually not doing this with an incisionalist approach. When the tissue is not at least 2 millimeters thick, we prefer to go ahead and extend our flaps with sulcular incisions, at least one tooth and sometimes even two teeth to either side of the tooth to be replaced. Whenever the interproximal bone is healthy on the adjacent sites, there really is no danger to be able to do a sulcular approach, as there really should not be any reduction of papilla height if the underlying bone is healthy. This also gives you good access to the surgical area, and whenever the bone and the tissue are thin and need to be augmented, we will do this with an incisioned approach, and we really try to avoid an incisionless entry. We want to be able to see exactly what this area looks like and be able to regenerate the thin labial bone and tissue at the same time as immediate implant insertion. A Boozer elevator, a micro elevator, is utilized in the papilla region to initiate reflection of the flap, and the flap is reflected with full thickness dissection. We raise the palatal tissue away from the palatal bone to be able to get complete access and visualization of the extraction site. At this time, we can evaluate the thickness of the bones, the height of the interproximal bone, and make sure that we can avoid that thin labial plate of bone. Initial drilling of the osteotomy site is garnered through placement of the drill towards the palatal wall, making sure to stay away from the buccal plate by a minimum of 1 to 2 millimeters. We're going to go ahead in this case and place an immediate tapered internal laser lock implant from BioHorizons. And what you're seeing here is the initial drills that are being utilized, first the pilot and then the twist drill, 2 millimeters, to initiate the direction of the implant. And as we step up to the dedicated drills, the 3.2, and we expand and enlarge the osteotomy site. You can see once again we're not guessing the location. We're able to completely visualize the labial, and we can see we can harvest some of the bone on the drill utilizing a bone trap. And just to focus again on the dedicated drills as part of our initial osteotomy site, we're now going to go up to the 3.8, the green striped dedicated drill, and we're going to be looking to place a 13 millimeter implant in this area. Again, making certain to engage only the palatal and mesial-distal walls and always staying clear of the buccal plate. Placement of the drills and the utilization of a slow speed RPM, usually at this stage, is approximately 200 or less, to make sure that we can garner vital cells during the drilling sequence. And we utilize these bone chips that we harvest with slow drilling according to Dr. Anitwa's protocol. This bone can be mixed with synthetic bone, and now we're testing the osteotomy site utilizing a surgical analog. A bone tap is then utilized as the final drill to make sure that we have clearly tapped the cortical walls of the socket on the palatal mesiodistal walls, and then the insertion of the internal laser lock BioHorizons implant being inserted first to 20 Newton centimeters and then increased to 30 Newton centimeters and then eventually to 40 Newton centimeters of initial torque insertion stability. You can see the carrier assembly being positioned ideally 1.5 millimeters or more away from the adjacent natural teeth. No trauma has been done to the labial bone or the interproximal peaks of bone of the adjacent teeth. Final hand ratcheting down beyond 45 Newton centimeters for the final depth of the implant placement. And at this point, we can decide where exactly the head of the fixture should be located. We prefer to make certain that the head of the fixture should be 2 to 3 millimeters below the future gingival margin of the proposed restoration. One of the advantages of a laser lock surface is we have the versatility to either leave the 8 micron surface below the bone, the 12 micron surface slightly at the crest or above the crest. Either way, this versatility allows us that ability to place the implant appropriately in the aesthetic environment. Removal of the carrier is then performed, and you can see that the implant is placed ideally for the future restoration, and just the microchannels that are appropriate for soft tissue integration and connective tissue attachment are left just slightly above the bone, only on the labial aspect. Healing abutment with no flare is inserted, and then a particular bone graft utilizing PRGF, a BTI product, in a protocol that was designed by Dr. Anitwa. Plasma-rich in growth factor is added to autogenous bone harvested from a slow drilling sequence, and in addition to a allograft irradiated bone and corticated bone is utilized to augment the thickness of the labial bone. Now, one of the reasons to utilize this method is to engage and preserve the remaining cortical walls of the labial bone, but also to increase the thickness, as we know from the literature from Dr. Grunder's work in 2005, and where he suggested 2 millimeters of bone on the labial is really the ideal amount to be able to maintain that bone even after remodeling occurs. You can see us packing that bone in utilizing a stoma bone packing instrument, and we're going to overcorrect the buccal plate, again mixing the plasma-rich in growth factors, which is an excellent carrier for this particular bone graft, a combination of allograft and autogenous bone mixed in some cases either with cortical bone or xenograft bone in order to have some of the bone being slowly resorbed. A fibrin, autologous fibrin membrane harvested from the PRGF protocol is then utilized as a membrane to maintain and cover the bone graft. And you can see one of the things that's excellent about the fibrin is we can get quite a bit of the fibrin, and we can place this on in layers. And as this fibrin sets in the mouth to the patient's own body temperature, it starts to constrict and forms a very nice seal around the bone graft, protecting the underlying bone graft and acting as a membrane. Usually the resorption of this fibrin occurs at approximately 3 or 4 weeks, at which time the underlying bone should be completely set and stabilized to the labial wall. In an area with vertical defects, we prefer to utilize a combination of synthetic membranes like PTFE, Gore-Tex, or resorbable collagen membranes in addition to the fibrin membrane. Careful split thickness dissection to release the flap, to be able to vertically position this flap to gain good closure is then performed. This is a vitally important part of the procedure as we go into the mucosal tissues beyond the mucogingival junction, up into the vestibule and the lip, and only at this point do we release the tissue and then place an additional piece of fibrin over the bone graft. And you're starting to see that the layered approach to this, first the extraction, the placement of the implant appropriately away from the labial bone, augmentation of that labial bone in combination with growth factors harvested from the patient's own blood. And the last part of the equation is the thickness of the tissue, which we mentioned early on. And according to Ronald Young's work out of the University of Zurich in 2007, really we prefer at least 2 millimeters of thickness of the soft tissue. Here we're utilizing an alloderm product from BioHorizons to thicken or further thicken the soft tissue. And one of the advantages as well of this material is it's been soaked in plasma-rich growth factor and then covered again with fibrin. So we have growth factors added to this allograft tissue, which acts not only as a soft tissue graft to thicken the tissue, but can also act as a vitally important, longer acting membrane for the bone graft. So we get 2 utilizations or usages of this very important material, one to thicken the tissue, and then of course one to add a longer standing membrane barrier function even after the fibrin resorbs at a period of 3 to 4 weeks. Suturing is then performed. In this case, we're utilizing 5-0 Vicryl, and we're going to use interrupted mattress sutures, and we're going to stabilize the alloderm to the flap at the same time as closure is performed. And one of the reasons I prefer to do this is that it secures and stabilizes the alloderm, which is ideal when you're going to be utilizing it in combination as a barrier membrane and an additional soft tissue graft. The sutures are going to be pulled down vertically, utilizing the vertical mattress approach, and is going to be tied off towards the palate. We enter to the base of the papilla on the palatal aspect, and we're going to do once again the stabilization of the alloderm, and then we're going to come through the base of the papilla and then the vertical tip on the way back towards the palate, and we're going to hike the flap up vertically over the healing abutment and over the top of the alloderm and fibrin membranes. Finalized closure on the adjacent teeth is then performed, and you can see that the ability for us to extend the flap sulcularly, hiding the vertical incisions whenever possible, in this case unilaterally behind the cuspid region, so we don't have to worry about scarring of this tissue or it showing upon smiling in the aesthetic zone, which is very important. Whenever possible, we prefer to hide our vertical incisions distally behind the canine teeth. This gives us access to the surgical site, gives us excellent visualization, and as I said before, as long as we have good interproximal bone support, we really don't have any problems with loss of tissue height interdentally in the postoperative course. Packing the bone down beyond the healing abutment, checking for the placement of that alloderm that is stabilized underneath the flap, making certain that it is not movable. And you can see that this soft tissue has now been placed right at the top of the 3 millimeter high non-flared healing abutment. Denture tooth is going to be placed back. So we're making sure that we cut it short, making certain that there's no contact of the replacement tooth on the arch wire with the healing abutment. One of the things we want to make certain is that there's no premature loading of the implant during the healing phase, during the osseointegration phase. Final horizontal mattress sutures are then utilized to tighten the contact and to tighten the seal of the soft tissue around the healing abutment. We believe this is extremely important to make sure that no materials can get in during the first few weeks of healing, while the soft tissue seal, junctional epithelium, and connective tissue forms around that healing abutment. What we're going to do in the next video is highlight for you the temporization stage at approximately 3 months.